So thank you so
Please
much.
proceed.
It's nearly 1:30 in India just now. But it's a pleasure to be here. I was hearing the previous talk and what a fine presentation. The sessions have been absolutely very, very good. So thank you. I'll just go ahead with my presentation. So we have studied this Ivabradine versus standard rate control therapy in rheumatic atrial fibrillation. We all know that atrial fibrillation, especially rheumatic AFib, is very, very common in developing nations, especially in India, and we are still struggling to come to the right therapeutic armamentarium for atrial fibrillation. Not only are these patients young, they are in the prime of their lives. We often dilate their valves, we often replace the valves, but atrial fibrillation often continues. Although the surgeons often do a maze procedure, but atrial fibrillation still represents a huge problem in India, in developing nations, and often these patients suffer, long-term complications because of atrial fibrillation and its hemodynamic adverse effects. So we thought of studying Ivabradine, and the background, as I said, that many patients, if rheumatic heart disease, they have long-standing atrial fibrillation, and rate control is often the default treatment strategy in them. We've had the CRAFT study published from India, wherein we tried to compare it with amiodarone. We had amiodarone in one arm and standard rate control therapy, beta blocker, calcium channel blocker, and digoxin in the other group. But we all know that amiodarone, of course, has its own long-term problems in young patients. So although amiodarone was found to be effective, but it's not a great choice for young patients with AFib. And this was the IHRS, or the Indian Heart Rhythm Society Atrial Fibrillation Registry from India, wherein we collected, it was about a 30-40 multi-center study. We just collected the demographics and the causes for atrial fibrillation and the clinical presentation of AFib patients in India. Published this nearly about 3-4 years ago, and we found that about 50% of the patients of atrial fibrillation in India have rheumatic AFib. And often rate control was the default strategy in about 75% of these patients. And of course, rate control is limited either to beta blocker, calcium channel blocker, or digoxin. As I said earlier as well, the younger demographic of these patients, often these patients are maybe, 18 years, 20 years, 25 years, 30 years old. So if the AFib and the rapid rate continues for a long time, we all understand that the patient can go into tachycardiomyopathies. And beta blocker, calcium channel blocker, although effective, they have their own limitations. So we need a drug which could override the, bad effects of beta blocker, calcium channel blockers. And this challenge led us to look at Ivabradine. So initial studies of Ivabradine paradoxically showed that the patients could be having higher rates of AFib. And as we all know, that inhibits the funny current, not only the pulmonary vein, but in the SA node as well. And it is hemodynamically neutral. It does not affect the heart rate, heart contractility. It does not have negative inotropic effects, does not adversely affect the beta blocker, the blood pressure, unlike the beta blocker and the calcium channel blocker. So all these hemodynamically neutral effects are a good thing, especially for young patients. The lack of effect on blood pressure, the lack of effect on cardiac contractility. And very, very importantly, there has been recent data to suggest, both experimental and clinical, that it can even slow the conduction in the AV node because of the HCN4 channels. The HCN4 channel is the main isoform expressed for the IF current in the AV node. And that is where Ivabradine can act and can slow down the ventricular rate as well. And there is some experimental data, as I said, and there were some clinical case reports also for Ivabradine to be used in AFib. So it represents a therapeutic option for patients of AF for rate control. It's a potentially attractive option. And this was the thing which led us to do a pilot study evaluating the role of Ivabradine for rate control in patients with rheumatic AFib. We published this a couple of years ago. This was a small study of about 80 odd patients, rheumatic AFib. And if you see, the AF duration was nearly 6.5 years. Patients were on maximally tolerated beta blocker or calcium channel blockers. And we gave them either Ivabradine in one arm or escalated the beta blocker, calcium channel blocker, if possible, in the other arm. And we found that Ivabradine did work. So this current study, we thought we should evaluate now the effectiveness and safety of Ivabradine monotherapy as compared to standard rate control agents. The previous study was a combination thing. So we thought of using it as a monotherapy, again, a single center study. This was again in rheumatic patients. And the inclusion group was patients of persistent or permanent atrial fibrillation who had a heart rate of more than 100 with underlying rheumatic mitral stenosis or mitral regurgitation who were not planned for a mitral valve intervention. And this exclusion criteria was taken because we all know that if you do a balloon mitral valvotomy or you do a surgical procedure, then of course you're altering the underlying hemodynamics, and the AFib can revert following the procedure as well rarely. So we did not want that to affect, potentially skew the results. So these patients all had either moderate mitral stenosis, which was not planned for a mitral intervention, or a moderate mitral regurgitation, not planned for a surgical procedure, and randomized them into two groups. And the two groups were, group A was Ivabradine. Patients initially, if they were taking some beta blocker or calcium channel blocker, they underwent a washout of the previous rate control meds. And we started Ivabradine, as we found in our previous study as well, in a dose of 2.5 milligram twice a day. And after 1 week, the dose was titrated to 5 milligram twice a day based on the heart rate response. At 1 month, patients who had an inadequate heart rate response, which was defined as less than 10% of heart rate reduction, the dose was up to 7.5 BD. And this was the maximum dose, 15 milligram. So this was the protocol, 2.5 milligrams starting, escalate at 1 week, depending on the heart rate response, and at 1 month escalated further to 7.5 BD. The standard therapy, of course, included beta blocker or non-dihydropyridine calcium channel blockers, started initially and then at maximally tolerated doses. So these were the two groups. And the follow-up was for 6 months, because this usually we give as a DM project thesis, and the student stays with us for about 3 years. So at the end of 1 year, the patients are recruited, and the follow-up was initially for 6 months, but now we are extending it. But this is the initial preliminary 6 month data. So 83 patients were included. The mean age, as expected for a rheumatic AFib population, was relatively young. About 1 in 5 patients were male. Again, this is expected in a rheumatic AFib population from India. Most patients are females. The AF duration was about 5.9 years. Baseline heart rate, as I said, was 101. The baseline heart rate was 101 plus minus 17. 6-minute walk test was 355 meters. The baseline LA size was 47.4, and we also did a baseline LA strain. And in this study, as we showed in the previous study, we have, now these two studies have also documented not only the effectiveness of Ivabradine, as I will show, but we also studied the left atrial strain in these patients. We wanted to see if it is making actual dent on the LA contraction parameters as well. So basal LA strain was 20, and the mean Ivabradine dose, which we finally achieved, was 9.8 plus minus 1.6. The metoprolol was about 102 milligram. Diltiazem was 131. And digoxin was used in a minority of patients, 0.25 milligram. This was the maximum dose of digoxin. So these were the doses which we could achieve. Both groups achieved a significant reduction in absolute heart rate from baseline to 6 months. The baseline heart rate in the Ivabradine group, as mentioned here, was around 105.98, and it reduced to 86 at 6 months. An absolute reduction of around 19 beats per minute, and the percentage reduction was around 18.5%. So pretty impressive figures with Ivabradine. 18% reduction in the mean heart rate. The heart rate reduction in the standard therapy was slightly less, numerically lesser. If you see, the final heart rate was 86 here and 82 here. The absolute reduction was around 9.5 beats per minute. The percentage reduction was around 10%. But the final heart rate, there was no difference in the p-value. So the result just suggested that both therapies were perhaps equally effective. If you see, the mean starting heart rate was slightly higher in the Ivabradine group, 105 versus 92, but again, this was statistically not significant. And the percentage reduction was comparable. So both groups were equally effective. Ivabradine did work, as shown in our previous pilot study as well as monotherapy. The final heart rate, as I mentioned, was similar in both the groups at 6 months. So this was the principal or the primary endpoint, that is the reduction in the heart rate. And if you see this over here, this is displayed pictorially as well. The blue bar is Ivabradine and the orange bar is the standard rate control therapy. The mean starting heart rate was around 105 versus 92. Again, p-values were not significant. After 1 month, the heart rate was lesser and it was sustained and a progressive decline at 6 months. So 86 versus 82, again, the values are comparable. The secondary endpoints, we had a couple of secondary endpoints as well because we wanted to show the effectiveness of Ivabradine beyond rate control. Measured the 6-minute walk test. It was significantly improved with Ivabradine expectedly because it is producing a reduction in the heart rate. So the patients could improve their exercise capacity. The mean 6-minute walk distance from 334 to 360. And there was no significant change with standard therapy. Now, whether this is due to the effect of beta blockers or calcium channel blockers on the cardiac parameters in terms of cardiac output or blood pressure, we don't know. But this was the observation we had, that Ivabradine and beta blocker, although they both produce reduction in the heart rate, the 6-minute walk test was more favorable with Ivabradine. We also measured the natriuretic peptides, and this showed a reduction with Ivabradine at 6 months and a sustained decrease till 6 months. At 3 months and 6 months, the BNP levels were significantly lesser with Ivabradine as compared to baseline. With standard therapy also, the BNP fell, but statistically significant change was achieved only by 6 months. So to reiterate, the heart rate was reduced by both therapies to a similar extent. The 6-minute walk test was more favorably influenced by Ivabradine, and natriuretic peptide reduction was seen with both. As far as symptom improvement is concerned, we took the standard EHRA classification, and the proportion of patients with EHRA class 2A, 2B, and 3 was nearly similar in the two groups at baseline. And what this goes to show is that in the Ivabradine group, nearly 17, 39, and 44% at baseline were in EHRA 2A, 2B, and 3. And in the standard beta blocker or calcium channel blocker group, it was 19, 43, and 38%, almost similar figures. What was more impressive was that among those on Ivabradine at 6 months, only 41% had residual class 2B, class 2B or 3 symptom, which is the one which we are more concerned with, class 2B or class 3, which are actually symptom limiting or activity limiting for patients. Only 41% patients had 2B or 3, as opposed to baseline, about 83% had 2A or 2B symptoms. So that figure fell from 83 to 41%, reflecting a significant symptomatic improvement in the Ivabradine group. Amongst the standard therapy also, there was improvement in symptoms, but if you see over here, 52% had residual class 2B, class 3 symptoms. So the symptomatic improvement in terms of patients' own assessment of their symptoms in terms of EHRA classification was again skewed towards or favored Ivabradine. So heart rate control similar in both. 6-minute walk distance, walk time better with Ivabradine, natriuretic peptide reduction similarly with both, and the symptom status improvement was again slightly favorable with Ivabradine. We also measured the LA strain because this was another eye opener for us, that commensurate with the heart rate control, the LA strain also improved similarly in both the groups. It was comparable in both the groups. And if you see the pretty dramatic figures, on the left is a patient at baseline. If you see, the LA strain is all over the place. It is dysynchronous, and with both Ivabradine and standard therapy, we could get some semblance of a better LA strain at follow-up. So this small study, again, it just goes to suggest that Ivabradine was not only found to be safe, patients tolerated it well in the doses used. It was equally effective in comparison to standard rate control therapy for rheumatic AFib. And for patients requiring rate control therapy or medication switches, supposing the patient is not tolerating a beta blocker or a calcium channel blocker, potentially we have this therapy to consider in times to come. Although again, as I mentioned, the limitation is a single center study, the limitation is a small number of patients, a small follow-up of only 6 months, but we are continuing to follow these patients, and I think Ivabradine might have some potential role in rheumatic AFib patients in the times to come. So thank you for your attention. Thank you so much.